Welcome, everyone. Thanks for joining on this wonderful February evening. So this is one of our Empowering Patients talks, sponsored by the Burnaby Division of Family Practice. And I'd like to introduce my partner in this program, Leona Cullen, who worked for the division, but we can't do this without Leona. And Leona's put together a lot of great resources related to our talks, but also related to all the activities in the Burnaby Primary Care Network and the Burnaby Division. So off to Leona.
Hi, everybody. Thank you for joining us. We had a really great attendance for this, so I'm really happy to see you all here. In the chat, I'm going to share some resources. One will be our Empowering Patients page. That'll tell you all of our upcoming talks, as well as recordings of previous talks if you weren't able to attend. Another page that I'm going to post has all of our resources. So Dr. Wong puts together information sheets for each of these talks, key point documents, plus the presentations for each of our talks for the last year or so. So those will be on a page. I'm going to share our Burnaby PCN website, and that has many community and physician related resources for you, so please check it out. There's lots there, especially for the Burnaby community. What else? Our weekly COVID roundup newsletter goes out every Friday. I'm going to post the last Friday's issue for you. You can subscribe to that. You just go to the bottom of the page and subscribe, and you'll receive one of those sometime on Friday. And I think that'll cover all our resources, but just look for them in the chat.
Great. Thanks, Leona. And thank you, Leona, for all the hard work you did to promote our talks and getting our Zoom meetings running so well these last 2 years. And again, this year, we've been doing them all on Zoom, but looking forward to actually seeing your lovely faces in person again when we're able and when we're all safe to do that. So, but it's a great way to reach lots of people that can't make it out on an evening when it's after dark too. So maybe we'll do a combination of both when the pandemic is hopefully in the past soon. And there'll be time for questions at the end, and not just about the talk, but also anything you want to ask, any COVID questions that I'm able to answer, but of course not personal medical questions. So brought to you by the Burnaby Division of Family Practice. And Leona mentioned the PCN, that's the Primary Care Network of Burnaby. And the Burnaby Division and the Family Docs are a part of that, but it's a big network of all the people and organizations that are supporting every member of our community, even before the pandemic, but certainly through the pandemic. So helping people struggling with mental health concerns, which has been really common for all of us during the pandemic. People struggling to find enough money and food to put on the table. And people just who need support, social support, because there's a lot of people that have been super isolated during the pandemic that don't have resources like families or neighbors that can help them out. So check out the Burnaby Primary Care Network and the resources Leona has passed on to us. That's actually me, not Captain America. And that was at the beginning of the pandemic where we enjoyed wearing PPE. Now we're getting kind of tired of it. So it's kind of refreshing for this hour and a half to take off my mask, because I've been wearing an N95 all day long. And most of the time when I'm outside of the office, I take it off to sleep with my wife. Again, the website for the Burnaby Division of Family Practice is divisionsbc.ca/Burnaby. And there you can find links to the PCN resources and also links to our Empowering Patients program, which is really a public health education program trying to give you unbiased information. Of course, it's always a little bit biased from my opinion, but evidence-based and not trying to sell you anything but personal wellness. Oh, I'm dedicating this talk to my dad, my dad, Tom Wong, Dr. Tom Wong, who's turning 92 on March 9th. I'm very healthy and very active and inspiration for me. So why are we here besides having parents that raised us? We're here because as family docs, we care about our patients. I know all of you that are my patients know how much I care about you, and all of you that are fortunate enough to have a family doctor to know over your whole lifespan knows that we really care about each one of our patients. And the golden rule of my practice with my staff, with Christina, we have a little hidden sign that reminds us that we treat every patient as we want a family member treated. So the same care, the same consideration, the same treatments, investigations, same specialists that we would want for ourselves or a family member. But we also care about our community, and that's the purpose why I spend extra time giving talks and writing for the newspaper over the past 30 years. I really care about the community that I grew up in, and I know that each of us in the community are dependent on one another to thrive and to be happy. And we care about our future because we're not going to be around forever. We'll eventually retire, and we'll need one another to look after ourselves socially, physically, emotionally. So we care about our patients and we care about our community. So today I'm specifically going to talk about heart health and heart disease. We'll talk a bit about how the heart works, how there are different types of heart disease. So we'll talk about the 4 basic types, the symptoms of different types of heart disease, and how to assess your personal risk for any of these. And of course, most importantly, how you can reduce your risk for developing heart disease, or if you have one of these conditions or at risk for them, how you can reduce the complications and still live a full and healthy life. To start with, I always ask, what is healthcare? And if you ask a family doc or anyone working in primary care in the community, like a nurse practitioner or a pharmacist or respiratory technicians and home care nurses, we say it's mainly what we give in the community, managing chronic conditions and prevention. But really, the person that provides most of your healthcare is, of course, you. We're here as your support, your coaches, and to connect you to the resources you need to stay healthy. So I think real healthcare is self-care. And the person that provides most of your healthcare is you. But you need support and unbiased information to support you with that. The best predictor of your future health are the habits you practice today, at least with those things like heart disease that is largely preventable. And the 4 foundations of your self-care, what you do for yourself, are what you eat, what you put into your body, what you do, physical activity, balanced by rest and sleep, how you feel, your emotional well-being, and how we connect, healthy relationships. So the 4 foundations are what you eat, what you do, how you feel, and how you relate. So these have been kind of core topics of our Empowering Patients public lectures. So for all of these talks that we've had in the past 3 years, we've actually been doing it for over 6 years, Leona and myself, but we actually have the most recent talks, and all these topics are actually listed on our website. So you can download the slides, similar to the slides we're using today. And these slides will be online because Leona is so efficient within a couple of days by the weekend. So in case there's nothing to watch on Netflix, you can probably watch the video on YouTube or any of these past topics, including how to communicate with healthcare providers, including me, the key information that you know to make informed decisions. And I'll be giving a few tips on what to ask practitioners about a medication they might be offering or a treatment that they might be offering, some key questions to ask them. So I'll throw those in at the end just as an extra bonus to our talk. We've also done topics specifically about diabetes and what you need to know about blood pressure, medical ethics, and the next topic, March 31st, our next talk is on the key symptoms you need to watch out for and what screening tests you need to do. So we're going to combine that together and give you some good, useful information, because a lot of my patients I haven't seen for over 2 years. And normally we see our patients at least once a year, could check the blood pressure and remind them of any screening tests. So this talk is coming up on March 31st. So kind of remind you what tests you need at different ages, but most importantly, what kind of questions we used to ask during the complete physicals, different systems, different symptoms that you should watch out for that might indicate that you might have a condition that needs medical attention. So that'll be a useful practical talk for all of us. So what do you need for good self-care? You need the knowledge, more than you can get on the internet and more than you would get with biased information on the radio or television or on Facebook. And you need support from peers who have common conditions and for us, the healthcare professionals that can connect you to the resources that you need. And we need to be planned and proactive in our personal healthcare. This is my opinion that health is not the absence of disease, and healthcare is not just the treatment of disease. I believe that every one of us, you and I, have a unique potential in this life. And it's our personal duty to realize that potential and to help others achieve theirs. And your positive potential doesn't mean being perfect, because none of us is, but it's guided by our personal values. So for good self-care, these three key things: healthy eating, healthy physical activity, medications as sometimes needed. So topic of today is how the heart works. So hopefully you'll learn something new. It's a very complex organ, but I'll try to speak in more common terms, but using some of the medical terms that you'll hear if you have a heart condition. So the heart is a very unique muscle because it's both a muscle as well as an electrical organ. It produces electricity. It has its own natural pacemaker in the right atrium, and then it conducts that electricity and causes the heart to pump. It's quite an amazing feat of evolution. And the heart is actually made up of 4 chambers. And so we talk about the right heart and left heart as one organ, but it actually has divided into the right side and the left side. And each side of the heart has a smaller chamber on the top. That's called the atrium. I think that's a Latin or Greek word for a small chamber or room, and a larger ventricle in the lower portions of the heart. So atrium and ventricle on the right and left. So we have a left atrium, left ventricle, right atrium, and right ventricle. So the way the blood moves through the heart is that the right atrium receives blood from the rest of the body. So that's blood from the venous system that returns to the heart. So this is blood that's already been circulated. Your muscles and your brain and other organs have used the oxygen that's rich in the blood. And so this is blood that doesn't have any more oxygen or deoxygenated blood. So it's returning to the body, into the right atrium, and then the right atrium pumps it into the right ventricle. The right ventricle pumps that venous blood or deoxygenated blood. We show it in blue on the picture there because it doesn't mean you're a king or queen when you have blue blood. It means it's deoxygenated blood. So it's darker color, like cyanosis. So that blue blood, deoxygenated blood, is pumped from the right ventricle right into the lungs through the pulmonary artery. And it's in the lungs. There's a connection with tiny blood vessels in the smallest packages and pockets of the lungs called alveoli, where that blood is receiving oxygen. And that oxygenated blood, the nice red, rich blood, is moved back into the heart. So it's the left atrium that receives this bright red oxygen-rich blood from the lungs and then pumps it into the left ventricle. And then the left ventricle pumps it to the rest of the body through the aorta. That's the main big blood vessel that comes up to the top of the heart, goes through the chest and into the abdomen and branches, so that blood that is rich with oxygen that all our cells need all the time can kind of nourish every cell and every organ, including your brain. So these 4 chambers of the heart pump the blood in a very orderly fashion because we have our built-in pacemaker. So it's actually part of evolution. In the top of the right atrium, the smallest chamber in the top of the right side of the heart, is called the SA, sinoatrial node. So when you see an EKG, if you ever see a report, it might say sinus rhythm. So that's a normal rhythm coming from that sinoatrial node, the natural pacemaker that's inside your right atrium. And if you look at that diagram, it sends the electrical signal throughout the atrium, goes down the atrioventricular node, which is between that atrium and both ventricles, and sends that electrical signal to tell the ventricle to pump after the atrium pumps. That's why the electrocardiograms give us a lot of information about the size and other things about the chambers of the heart as well. We can actually see from an electrocardiogram if the heart might be enlarged in the left ventricle. And we can see if there's something going on that might be delaying conduction through the heart as well. So how do you know if you're at risk for heart disease? Well, the simple answer is you are at risk. We all are. So the risk for heart disease increases as we age. And if you have a family history of heart disease, which most of us do have, because even if our parents lived to their 80s or 90s, they most likely died from a cardiac event, like a heart attack, or from heart failure, or perhaps from a stroke, which is related when we're talking about atherosclerosis or narrowing of the arteries. And although we can't change our age or genetics yet, family history can make us more proactive in recognizing and managing the modifiable risk factors, including our lifestyles. It can make a huge difference. So there's 4 main types of heart disease. A bit of a simplification, but it's much easier to kind of understand because I have a lot of patients that don't know the details of their parents' family history or grandparents, and they might just hear that they died from heart disease. They could have died from heart failure, which is different from a heart attack. And a lot of people don't know the difference between angina, which is one form of narrowing of the arteries, versus myocardial infarction, an MI or a heart attack. And sometimes the heart condition that a family member has is actually a valvular condition or a problem with a muscle that might contribute to a pumping problem with the heart or heart failure. Or it could be a rhythm problem, the conduction of electricity through the heart. So the 4 main types of heart disease are coronary artery disease, and I'll go into the details, but that's narrowing or disease of the arteries that actually supply the heart muscle itself. Valvular heart disease, which involves these valves that prevent the backflow of blood between the chambers of the heart and from the ventricles. And arrhythmias are problems with the electrical conduction, and heart failure is about the pumping action of the heart. So we'll go into each of these separately. We'll start with coronary artery disease. So the coronary arteries are specific arteries that are supplying blood just to the heart muscle themselves. So these arteries are actually on the outside of the heart. They take branches out of the aorta. Remember, aorta has that red oxygen-rich blood that's already been oxygenated by the lungs, and the aorta pumps it to all the organs of the body, including your brain and kidneys and all your other favorite organs. But because the heart is one of our favorite organs, the first branches from the aorta go directly to the heart muscle, what we call the coronary arteries. So these coronary arteries, you can see on the outside of the heart in this picture, deliver blood to every portion of the heart muscle. So we want to make sure those are all clean and supplying good oxygen-rich blood to those muscles so that the heart functions well. And when one of those coronary arteries supplying blood to the heart muscle is blocked, that area, the blood downstream, that heart muscle is starved of blood and it could die. So the result is a heart attack. So a heart attack or MI, myocardial infarction, is where there's complete blockage of an artery, and then the blood downstream doesn't get any blood supply and then quickly dies. So 2 gradations of coronary artery disease is that when an artery is partially blocked, like not 100% blocked, there's a decreased flow, just like a plugged up sink. It drains very slowly. But on the other hand, a blocked hose will supply the fluid coming out the tap very slowly as well. So with a coronary artery that's partially blocked or narrowed by cholesterol or plaque, the area of the heart muscle downstream that gets supplied by that blood vessel receives less blood than it needs. So when you're exercising that muscle, that heart muscle, when it's working harder at harder heart rates, like when you're exercising or doing some physical exertion, it doesn't supply enough blood for the demand at that time. So we call that ischemia or decreased blood flow. And the symptom is angina or chest pain. So generally chest pain that comes on with activity or other things that can cause higher heart rates, like a panic attack, increases the demand on that heart muscle. It requires more blood, but a partially narrowed artery won't supply enough blood. So it causes the symptom of pain. So here's a picture of a normal coronary artery on the top that's nice and clear and pristine, like when we're babies. Gradually over time with age and accelerated by some things like smoking or high blood pressure or very high cholesterol and fat in the diet, plaques or narrowings occur throughout the blood vessels, throughout the whole body. But when it happens in a coronary artery, it can cause that angina from decreased blood flow, ischemia. But if that artery is totally blocked by a plaque, like a irregular block of cholesterol that fell off and totally plugged up the blood vessel downstream, or just a blood clot that forms in a narrow blood vessel, that causes a complete obstruction, and that causes the heart attack or the death of the heart muscle downstream from that blood vessel. So this is the most important. The symptoms of a heart attack, also called an MI or myocardial infarction or death of heart muscle. It can be chest pain that we classically know. It can be pain or pressure, often classically described as a squeezing pain. But please don't, it's not always in the chest, and it's not always squeezing. It's just the classical description in a large number of people. It's often accompanied by nausea. So a lot of people mistake it for an upset stomach when they have a heavy meal. So it's a queasiness and a nausea. And that's just because of our parasympathetic nervous system that gets affected by what's going on with the heart when the heart muscle is damaged. So often we're sweating at the same time. It could be a cold sweat. And often there's difficulty breathing because we are not getting enough oxygen to all the crucial areas of our body. So the classical symptoms, chest pain or pressure, could also be felt in the throat or the arm, nausea, sweating, and difficulty breathing. The symptoms of angina when an artery is partially narrowed and then you're feeling it when you're exercising or when you're anxious, another time when our heart beats fast, can be chest and throat pain and pressure, so very similar. So some people feel it in their throat, sometimes in the arm, but the key is it comes on with physical activity or anything else that makes the heart go faster, which might include a glass of wine that makes the heart faster, or anxiety that makes the heart go faster. So when a doctor in the emergency or your family doctor asks you, do you get increased chest pain or throat tightness or arm tightness or pain when you're anxious, we're not thinking it's a panic attack, but that's one of the indications that if your heart rate is going faster, like when we're anxious or had an argument or when we're angry, that could be similar to the effect of exercise. So symptoms that come on with exercise or other things that increase the heart rate, increased demand of the heart muscle, and could be a symptom for angina. A heart attack doesn't necessarily come on with exercise. It could be a sudden blockage, so it just comes out of the blue. And we need to be really attuned to it and call 911 right away, even if there's any doubt. We don't want to wait another minute to see if it gets better, or waiting an hour is even worse, because the longer we wait, if the heart muscle is being starved of oxygen, every minute matters. Now, I've talked about the classical symptoms, but there's a lot of people that can have what we call silent or atypical ischemia or a silent heart attack. So these patients might have a heart attack or angina, but they don't present in the usual symptoms of that squeezing, chest pain, throat pain, or neck pain or arm pain. And we found that it's more common in women and more common in people that have diabetes, that it just has a different presentation. And that's why it's so important to know these other symptoms that could indicate angina or a heart attack as well. It's a real shame that a lot of women do get heart attacks, go to emergency, but it's not recognized as a heart attack. And we'll go over the symptoms that get mistaken for other things. So pay special attention to these other symptoms, because men and women don't always present the same way. So in men, the typical symptoms, chest pain or discomfort, maybe a rapid, irregular heartbeat, feeling dizzy, faint, or lightheaded, breaking out in a cold sweat, feeling discomfort in the stomach, like nausea and queasiness, and shortness of breath. If you look at someone that's having a heart attack, they don't look well. They're sweating, they look pale, but they can have any of these symptoms. You don't have to have all these symptoms to be at risk for a heart attack. Women could have chest pressure, not necessarily pain, or they may not have any chest symptoms at all. The symptom could just be extreme tiredness and fatigue for several days. So those could be symptoms of a heart attack coming on or already completed. Women might have anxiety or disturbed sleep um, because of feelings of unease and nausea as well, or an irregular heartbeat. And you can see how easily that gets written off or mistaken for something else. Or atypical symptoms can be pain in the back, in the arm, in the neck, or in the jaw. That's different and can't be explained by other things. Although we're always searching for other reasons to justify the pain. And of course, nausea and stomach upset could be a symptom. And of course, shortness of breath. So kind of be aware of those really hard to identify symptoms like extreme fatigue and tiredness. Of course, nowadays it could be a COVID infection, but keep in mind if you have risk factors for heart disease, like a family history, or if you have diabetes, or high blood pressure, or a smoker, don't assume tiredness is just COVID this time, or just not enough sleep. If it's something that's extreme and different, don't hesitate to call your family doctor. If you have a high suspicion of a heart attack, don't hesitate just to call 911. So atherosclerosis, or narrowing of the arteries, doesn't just occur in the coronary arteries that supply blood to the heart. It could be any blood vessels. So if people have narrowing of their arteries, or atherosclerosis, for the blood vessels supplying blood to your legs, we call that peripheral narrowing of the arteries, or atherosclerosis. The typical symptom would be pain in the calf when you're walking. We call it claudication. And the key feature is that we all get sore muscles if we're walking too much or running too much. But when it's due to poor blood flow, when you're demanding more from your muscles, as soon as you stop walking and resting, even if you're still standing, then the pain instantly gets better. And then when you start walking again, increasing the need for blood to supply the muscles, then the pain comes back again. So that's a suspicious symptom that you might have narrowing of the arteries that are going into your legs, like the femoral artery or the popliteal artery behind the knee. So if you get those symptoms, you're also at risk for having narrowing of the arteries elsewhere, like the heart as well. It's the same risk factors. Some people will get abdominal pain when they're exercising or when they're eating, anything that's increasing the demand and the movement of blood. So this is called mesenteric ischemia if it's actually due to narrowing of the blood vessels that are supplying the intestine and the stomach. So these are all examples of decreased blood flow, or ischemia, or lack of blood flow. So when we're working some organ or muscles harder, and it causes these symptoms, and then at other times the pain is relieved, it's suspicious for ischemia from narrowing of the arteries elsewhere in the body. So narrowing of the arteries or atherosclerosis can affect anywhere, as I mentioned. When it affects the blood vessels like the carotid or vertebral arteries that supply blood to the brain, or some of the smaller blood vessels, it can cause strokes or transient ischemic attacks, like stroke-like symptoms, loss of sensation, weakness, difficulty speaking that are transient and last less than 24 hours, or strokes that are symptoms that last more than 24 hours. Again, like a heart attack, if you have any stroke symptoms or a loved one does, just call 911. Don't hesitate, or wait till you get an appointment with your family doctor, or waiting until you can find a family doctor. So those are emergencies. It can happen to a blood vessel that supplies blood to your eye, to the retina. Retinal artery occlusion can be a cause for blindness or permanent vision loss. So if you have a sudden loss of vision, again, another emergency, 911. And again, peripheral vascular disease, we talked about that claudication, the pain in the calf when you're walking that's relieved by stopping walking. And if this isn't treated, it could lead to amputations. And one cause of kidney failure is due to narrowing of the arteries, the renal arteries that supply blood to each of your kidneys. So that's why high blood pressure, high cholesterol, and the other risk factors for narrowing of the arteries, atherosclerosis, can also affect kidneys. So I'll go over the risk factors for atherosclerosis anywhere in the body. So number one is blood pressure. So blood pressure for most adults should not be over 140/90 when you're at rest. So the general rule is that most adults should be checked annually for their blood pressure. So we haven't been doing such a good job in the past 3 years because of the pandemic. I've advised a lot of patients at risk for high blood pressure or who have increased or borderline blood pressure to actually get an inexpensive blood pressure monitor. There's specific brands I often recommend just because they're more reliable. But if you want to see those brands, you can look up Hypertension Canada. It actually has a list of approved brands that they've calibrated as well. And I give my personal favorites to my patients as well for what brands to get. So, because if you're relying on your home blood pressures and we're relying on it, we have to make sure it's a reliable machine. So most adults should be checked annually. And if you do have high blood pressure over 140/90, it should be checked more often. Initially, it's treated with diet, reducing red meat, eating more fish, more whole grains, more green leafy vegetables, and low sodium or salt in our diet. It's treated with exercise, because 30 minutes of moderate exercise, like just walking 15 minutes twice a day, over the course of a week, like 150 minutes total, has been shown to be effective in reducing high blood pressure as well. Reducing alcohol makes a big difference if you're a daily drinker, because the heart is stimulated by alcohol as well. And of course, medication is appropriate if it remains over your target of 140/90, or in some people, they have lower targets because of diabetes or existing heart disease or kidney disease. The second risk factor after high blood pressure is diabetes. So this, we used to screen everyone over 40 with fasting sugars, but now we kind of determine if someone is at increased risk. Most people after 40 should talk to their doctor to see if they should be doing regular screening and how often for diabetes. And we'll go over a little bit more detail at our March 31st talk about specifically how we test for diabetes as well. People with established diabetes are, on average, are considered high risk, like over 20% risk of having a heart attack over the next 10 years. So we actually have lower targets for blood pressure, 130/80, and lower targets for the cholesterol as well. And of course, very high cholesterol can be treated with diet, exercise, and sometimes medications if someone is at higher risk for going on to narrowing of the arteries or atherosclerosis. So our third risk factor is high cholesterol. And of course, family history. So a first degree relative would be like a parent or a sibling or your child. So if you have a first degree relative that has had angina, chest pain, or heart attacks under the age of 65, you're at increased risk for heart disease as well. And one very modifiable risk factor is smoking. So not so much from the nicotine, which does stimulate the heart and the heart rate as well, and can increase blood pressure, but all the other toxins that's in tobacco that we inhale. So that causes tremendous damage to the lining of our arteries. So smokers are at tremendous risk for narrowing of the arteries, and especially not only heart attacks and strokes, but also narrowing of the arteries to your limbs. So what we call peripheral vascular disease. So a lot of my patients that have had to have amputations of toes or feet were heavy smokers that weren't able to quit. And of course, other risk factors too. So how do you test for this first type of heart disease, coronary artery disease, or narrowing of the arteries that supply the heart muscle? So one test is the electrocardiogram. Another is the exercise treadmill test or stress test. The third is the MEB or percentine test that's done in the hospital to check on blood flow to the heart. There's the CT angiogram and there's the classical angiogram. So I'll go through each of these. So the electrocardiogram, you'll hear us call it ECG or EKG. So EKG is kind of the German form for electrocardiogram with a K, but we like to say EKG because it's easier to say. It doesn't get confused with an EEG, which is an electroencephalogram that we use for investigating after strokes or after a seizure for epilepsy. So EKG, ECG are the same things. Those are the leads we place on the heart so that we can check the heart rhythm. So very handy to have. We often send someone to the lab to do that, or we do it in the hospital if someone has some symptoms that we need to monitor as well. So in the past, when I've had patients come in with a regular heart rhythm that I suspect just from clinical practice is a certain pattern that we can tell that's totally irregular. We call it irregularly regular when I'm listening to someone's blood pressure. And I notice the pulse is irregular without any pattern to it, and then listen to the heart to confirm it. So in the past, I would have to send the patient to get an electrocardiogram at the lab right away. But now I've been just taking off my Apple Watch and putting it on the patient's wrist after cleaning it and actually confirming the rhythm. So it's actually kind of a handy thing if you're at risk for atrial fibrillation or get a cardiac arrhythmia. It's kind of handy to have it on your wrist, and you can do a one lead EKG to get the rhythm. You can actually print it out and send it to your physician. So one of my patients didn't use an Apple Watch. He actually bought another product on Amazon called Kardia that was really handy for him to detect that his regular heartbeat was atrial fibrillation. So that was really helpful for detecting that early. The exercise treadmill test is if we have a high suspicion that someone's chest pain that comes on with exercise or stress can be a problem with blood flow in the heart, there is an exercise stress test which does the electrocardiogram at the same time as checking the blood pressure during exercise, either riding a bike or going on a treadmill. So a certain protocol called the Bruce protocol where they increase the work of exercise and then monitor the electrocardiogram to see if there's some rhythm changes that are suggestive of ischemia in the heart. It's just so amazing that we can detect this with just the electrical activity from the heart conducted through leads on the chest and body. So this test is about 70% sensitive. We can get some false positives, meaning it's abnormal, we need to do more tests, but we can also have a test that comes back normal. So if we still have a lot of suspicion that this could be ischemic heart disease or angina that we're just not picking up on the exercise treadmill test, often a cardiologist will send or recommend an MPI or a MEB, which is a nuclear stress test. So there's some radioactive, small trace radioactive material that's injected into the bloodstream. And then a medication is given, such as Persantine, that makes the heart pump a little bit faster. So it is like exercise without having to exercise. And this one is much more sensitive because it gives an indication of the flow of the heart muscle and how the heart is contracting as well, in coordination to the effect of the stress of the increased heart rate. So this is much more sensitive, about 90%, not 100%, but 90%. If we're still suspicious that maybe the MEB is missing something, that there could still be narrowing in the arteries, depending on the patient's ongoing symptoms and other risk factors, we could actually do a CT scan where some dye is actually injected. So that actually we could see the outline of every artery in the heart. So it's a CT angiogram. And it's relatively quick, but it's hard to get. Pretty well only the internist and cardiologist can order this. So I would have to refer to a specialist if I was really suspicious, and they would decide with the patient if this is an appropriate test for them. So this is fairly quick, just like a regular CT scan. And a classical angiogram is where they actually inject dye into the blood vessel. And then with X-rays, we can see the flow of blood through those arteries. So it shows a lot of detail, even with X-ray, without a CT. So this is the classical angiogram. How do we treat coronary artery disease? So one is angioplasty. And angioplasty is similar to what you saw with the angiogram. So you would actually, the cardiologist, what we call an interventional cardiologist, will actually see this live image of blood flowing through the blood vessel and see where it's narrowed. And they can put in a very small stent through the blood vessel to the area of narrowing and open things up and leave a little stent, which is like a piece of metal wire that opens up that blood vessel. So some of them contain medications. We call that drug-eluting stents that actually release some medication that prevents it from narrowing down, or some are just bare metal stents, and there's pros and cons for both of them. But it's up to the expert cardiologist, interventional cardiologist, to decide what's the most appropriate for that patient. So if it's a small stretch of an artery that's narrowed, maybe just a centimeter or two, we can put in a little stent that keeps things open, and then manage with medications to prevent that from narrowing up again. If it's actually a long stretch, or maybe the whole entire coronary artery that's blocked, that's where you do a bypass graft. So you might hear of a relative having double bypass, triple bypass. Doesn't mean they went 3 times or 2 times. It means triple bypass means 3 coronary arteries are blocked. So they had to remove a vein from the lower limb, use that vein to work as an artery to bypass that narrowing. So a little detour, a permanent detour. Like if a tunnel collapsed on the Sea to Sky or on the Coquihalla, then we'd have to create kind of a bypass if we can never unplug it again, if it's too long a stretch. So a coronary artery bypass, it'll be a cardiac surgeon, not a cardiologist, that actually does that surgery. Salvages extra vein from the leg and then moves it onto that to bypass that blocked long area of an artery. And that provides good blood flow as well. Some people have just diffuse heart disease where there's no critical narrowing that we just prevent with medications. And we'll talk about some of those as well. But usually it's medications to prevent blood clots like aspirin, medications that improve the health of the arteries on the inside, or to reduce blood pressure like what we call ACE inhibitors, like Ramipril, and medications to reduce the formation of cholesterol or to stabilize cholesterol plaques, like the statins, such as Crestor or Lipitor. And of course, you'd want to control diabetes if someone has it, control blood pressure so that it's not continuing to damage those arteries, and quit smoking if someone is smoking. So if you suspect you're having a heart attack or you're with someone that may have any of these symptoms, even the atypical symptoms of a heart attack, call 911, just like you would of any stroke symptoms. Immediately call 911. So the second type of heart disease, we've just been talking about narrowing of the arteries or coronary artery disease. So the second big type is valvular heart disease. And these are age-related and often genetic as well. So there's 4 heart valves that we talk about: the mitral, pulmonary, tricuspid, and aortic valve. So you can see the valves prevent one-way flow. They prevent the backflow of blood from one chamber to the other. So we talked earlier about how the right atrium contracts, sends blood to the right ventricle. So between those chambers is the tricuspid valve, and that prevents the backflow from the right ventricle back into the right atrium, because we only want one direction. And then blood from the right ventricle is pumped into the pulmonary artery. So that's where we have the pulmonary valve. So blood flows from the right ventricle towards the heart through the pulmonary artery. We don't want that backflow back into the right ventricle. And then blood's going to return, the oxygenated blood is going to return to the left atrium. And that left atrium, between the left atrium and the left ventricle, then we have the mitral valve, and that prevents that backflow as well from ventricle into atrium. And then again, remember, the left ventricle sends that oxygenated blood to the rest of the body through the aorta. Well, we have the aortic valve that prevents the backflow from the aorta back into the right ventricle. So we know with our training where to listen on the heart and detect which of these valves may be involved. And they have particular sounds if a valve is narrowed or if it's regurgitated and floppy. So a valve could either be stenotic or narrowed, or incompetent and floppy. So when a valve is narrowed, we call that stenosis. An example is mitral valve stenosis. Or the valve could be really floppy and allow backflow. We call that regurgitation. An example is tricuspid valve regurgitation. So if you do have valvular heart disease, the symptoms could include chest pain. For example, that's a classical symptom of aortic stenosis. So you can imagine the aortic valve being narrowed. And of course, that's where the ventricle is contracting, the left ventricle is contracting, sending blood into the aorta to the rest of the body. So if you're not getting enough blood coming out of that, supplying the heart muscle itself, you'll probably get chest pain as well with severe aortic stenosis. And of course, you'd be fatigued because the blood's not getting to all your muscles, or you can get shortness of breath when you're exercising. So these symptoms could be the symptoms of angina or ischemia, but it could also be from narrowing of the aortic valve or some of the other crucial valves. And a murmur is a sound that we hear with our stethoscope. Well, I put my stethoscope away already. So we listen with the stethoscope. We actually have two sides to this stethoscope. We have the diaphragm and we have the bell. Oh, here we are. Here's my stethoscope here. So the diaphragm is the flat one, and you see us use that most of the time when we're listening to the lungs, to the bigger, wide, flat one. So that's good for really high frequencies, but really low pitch, low frequencies, we actually use the bell on this side. And then some of us have kind of fancy cardiology stethoscopes. So this one can do both. So if I put it on lightly on the skin, on the chest, it acts like a diaphragm. If I push firmly, if I push firmly, it acts like a diaphragm. And if I just do it lightly, then it acts like a bell. And as we get older, or in noisy environments like the emergency or the hospital, these newer electronic stethoscopes, you'll probably see more of these. So these kind of amplify the sounds, making it much easier for to isolate sounds or to hear a really faint murmur. So if you see a stethoscope that kind of lights up, we're not recording, we're just actually listening during the time of COVID. So that's what a murmur is, a sound that we can hear. And there could be innocent murmurs, as we commonly hear in young children, which is a kind of a very soft murmur just due to flow. We call that a flow murmur. But if accompanied by symptoms or with family history, sometimes investigate further. And that investigation is an echocardiogram, which is a special type of ultrasound over the chest, where we can actually see the chambers of the heart contracting, and we can actually see those valves opening and closing. So an ultrasound technician has had extra training so that they are able to get all the images and do all these measurements of the chambers of the heart and of the valves, and to actually measure the amount of blood flowing through each chamber. So it's pretty amazing all the detail that these ultrasound and echocardiogram technicians can do. So treatment for valvular heart disease could be periodic echocardiograms every 1 or 2 years, depending on the degree of stenosis or narrowing or regurgitation or the heart function, how the heart's pumping. But in some cases, if it's severe, they do surgery. And it's not necessarily open heart. They're doing some surgeries actually through just going through the aorta, the big blood vessels, and actually replacing a valve. It's pretty amazing with less invasion, but they can be replaced very safely in the hands of expert cardiothoracic surgeons. Some people that have certain types of valvular heart disease. So if you have mitral regurgitation, aortic stenosis, talk to your physician if there's any special precautions you need to do. Some people have certain types of valve disease that require preventive antibiotics because of the flow is so turbulent or uneven. So certain types of valvular heart disease, if you were to get bacteria in your bloodstream, it could seed onto the heart valve and cause what we call endocarditis, an infection within the heart itself. And that can cause further damage to the heart muscle. So if you have a dental procedure or urologic procedure, that can release bacteria from those organs into the blood. So that's why some people need to take an antibiotic like amoxicillin an hour before they go for dental work or dental cleaning, just to prevent any bacteria to get into the bloodstream and seed onto a heart valve. So my patients with these conditions, they know in advance that they have these conditions, and we kind of have standing order for antibiotics before they go for dental work. So the third main form of heart disease are arrhythmias, or irregular heart beats or rhythms. So an arrhythmia is an abnormality in the rhythm or the beats or contractions of the heart. So tachycardia means a heartbeat that's too fast. And then generally at rest, our heart rate is between 60 and 100. So some of us that do too much exercise, like myself, have a heart rate that's lower than 60. That would be classified officially as bradycardia, but it's not unhealthy because my heart rate's around 50. And people that do lots of marathons can have heart rates in the 40s. But heart rates that are much lower, especially in the elderly, can result in decreased blood flow to the brain and fainting. So it could be abnormal and require treatment, depending on the circumstances. Premature beats are beats that come a little bit too early than they're supposed to, and pauses are delayed beats. And one particular arrhythmia, ventricular fibrillation, is when the large chamber of the heart, like the left ventricle, instead of pumping in an orderly fashion to supply blood to the heart and the brain and the muscles, it's just fibrillating, no pattern to it at all. It's not pumping nice and evenly or fast and evenly when you're exercising. So ventricular fibrillation could result from a heart attack, but there's no blood supplying. The blood isn't moving forward to all your crucial organs. And people can just collapse if they're in ventricular fibrillation. So that's why in public places and in the hospitals, we have the defibrillators. So if someone passes out, we can put these automated defibrillators right on the chest, detect if they're in atrial fibrillation, and follow the prompts, and the defibrillator does its trick. And then that electroconduction to just restart the heart. Atrial fibrillation is an irregularity in the atrium, that little chamber. And of course, as you recall, it's the right atrium that has the pacemaker for the heart. So if the atrium is fluttering or fibrillating irregularly, it's not pumping large amounts of blood regularly into the ventricle. So that's why we can detect when we're checking a pulse irregularly, irregular heartbeat. So people that have atrial fibrillation, because blood that's not pumping regularly can actually just sit still. And as you know, if you've had a nosebleed or other forms of bleeding, if blood is just sitting there for a while, it'll just clot. So people with atrial fibrillation, the blood can clot. And if the heart suddenly contracts, a big contraction, that blood can go through the ventricle, up in the past the coronary arteries, into the aorta, up in the carotid artery, and cause a stroke. So that's why people with atrial fibrillation are often offered medications called blood thinners or anticoagulants. I like to tell the story that when I'm at the public pool, there's a lot of people that know that I'm a physician. So sometimes a random person will ask me a medical question. So this young man came out of the steam room with a bunch of seniors, and then he asked me, why does our blood get thick as we get older? And I said, that's a funny question, because our blood doesn't get thick as we get older. Where did you get that idea? And he said, I was just talking to all the old men in the sauna, and every one of them is taking blood thinners. So I explained to him, they're probably taking a medication like warfarin or Coumadin to prevent blood clots because they have an irregular rhythm, which is more common as we get older and with other risk factors. They probably have atrial fibrillation. They're probably taking a blood thinner to make their blood extra thin. So that is the main treatment, anticoagulation. If you are at higher risk for getting a stroke versus the risk of anticoagulation. So traditionally we used warfarin or Coumadin that requires a lot of regular monitoring with the lab to get it nice and even, because there's risk with too much Coumadin or warfarin or too much blood thinning. Also, warfarin and Coumadin have a lot of drug interactions. So whereas 10 years ago, everyone that's anticoagulated would be on warfarin or Coumadin, now there's novel oral anticoagulants that are just taken once or twice a day, depending on the type of drug or the condition, and it doesn't need to be monitored. But they all have risks for causing more bleeding. So usually we would sit down and go through an algorithm that is evidence-based. That tells us if for an individual based on their age and risk factors, are they at higher risk for a stroke from their atrial fibrillation, or are they at higher risk for actually bleeding from a hemorrhagic stroke, bleeding in the brain, or bleeding from the stomach or the bowel because of the blood thinner. So we can do a calculation to decide the risk and then discuss it with the patient to help them make the best choice for themselves. So weighing the relative risks and benefits. And arrhythmia could also be treated, other types can be treated with medications that slow down or control the rate, such as beta blockers or pacemakers. So pacemakers are little small things that are put underneath the skin, but the leads actually go to the heart to take over the conduction of electricity. And a lot of patients with heart failure or certain arrhythmias might actually have not only a pacemaker, but an implanted defibrillator. If that risk of going into ventricular fibrillation at any time, it's like such a high risk that, and they don't live close to a defibrillator where someone can look after them all the time. This actually gives them the shock. It detects whether or not someone's going into ventricular fibrillation, it'll automatically give them a shock. One of my patients had these, and he would periodically describe what it felt like, getting a little jolt in his chest, knowing that his life was saved one more time at home. The symptoms of arrhythmias might be nothing. A lot of them were just discovered kind of randomly when the patient comes in. But just last week, a patient presented after being in emergency in the Okanagan with the symptoms of heart failure, which I'll go over in a second, like fluid in his lungs, shortness of breath, retaining fluid, swelling ankles. They couldn't figure out what the cause was. They suspected he may have pneumonia, and they treat him with antibiotics and steroids as well. And his electrocardiogram, the time they saw him was fine, but when he came into the office, I detected that irregular rhythm, which is typical of atrial fibrillation. And then I had my Apple Watch that I slapped onto him after I cleaned it with alcohol, and that confirmed that he was in atrial fibrillation. So some people have the arrhythmia going in and out, and they can present symptoms, no symptoms at all, or it can show the symptoms of heart failure, shortness of breath, chest pain, or they might feel palpitations, irregular beats, or fainting spells. One of my patients about 20 years ago fainted in the washroom at the movie theater, and we could not figure out what the cause of the fainting was. We did monitors after monitors after monitors, but eventually one monitor was able to pick up paroxysmal atrial fibrillation that periodically would go into the irregular rhythm. And now that we knew that, we knew how to treat it. So the tests include an electrocardiogram, which only shows the rhythm during that 1 or 2 minutes that the electrocardiogram is on the person's chest. We can use a Holter monitor, which is an EKG we can put on at the lab that's on for 24 hours, sleeping and awake. We still might miss some. So if a patient's symptoms are highly suspicious, we often get them something called an event monitor. So they can wear it for 2 weeks and then press a button when they're getting symptoms. And then often it might be picked up on an exercise treadmill test. And as I already mentioned, some people are using the Apple Watch to detect atrial fibrillation as well. And heart failure, the fourth type of heart disease. So heart failure is not the same as a heart attack, but of course a heart attack that leads to the death of heart muscle can lead to heart failure. But essentially heart failure is when the heart is not pumping and contracting to its usual ability. So we have a particular measure for the left ventricle. As you recall, that's the main chamber of the heart that's pumping the oxygen-rich blood that's been oxygenated by the lungs to the rest of the body, through the aorta, to the coronary arteries, to the brain, to every favorite organ. So if the left ventricle ejection fraction is below a certain number, normal would be in the 60s. If it's below 40%, as judged by an echocardiogram or an MPI, that MEB scan, both of them can detect, although the echocardiogram is usually the usual standard or reliable one. If it's less than 40%, we call that congestive heart failure. The heart is not pumping as strong. And the symptoms can be fatigue or tiredness, especially when you're doing physical activity. That could be walking up the stairs, doing laundry, even walking a little bit faster, walking uphill. These could be symptoms of heart failure. It could be shortness of breath when you're lying down, because if the heart is not pumping out the blood, it can flow back into the lungs and then cause congestion into the lungs too. So another symptom could be waking up in the night short of breath. It may not be asthma, but it could be blood pooling into the lungs when we're lying down. You know, during the day, blood tends to flow to the legs, and the legs may get a little bit swollen as we get older. But at nighttime, it just redistributes and goes into the lungs as well. If you suddenly get weight gain, like 5 pounds in a couple of days or 10 pounds in a week, that's not from overeating or all you can eat. It's from most likely from fluid. So that's one of the symptoms we have people at risk for heart failure to kind of monitor. If their weight suddenly increases in a matter of days or in less than a week, a significant weight gain. And of course, swelling of the feet and legs. As we get older, most of us will get some edema or swelling of the legs and feet, and often due to just the veins, the varicose veins or valves pop in the legs, similar to valves in the heart, but they pop more easily in the legs, and we can get swelling of the legs that come on kind of gradually. But of course, if you have acute sudden swelling in one leg with pain, that could be something else like a blood clot. So don't ignore that if it's something that's new and different for you or associated with pain. So common causes for heart failure, besides aging itself, because the heart doesn't pump as strong as it does when you're 80 years old compared to when you're 20. So the common causes are high blood pressure over many years. High blood pressure causes the heart to enlarge. That's why often the electrocardiogram, if a patient has high blood pressure, we often send them for electrocardiogram because that can show us even before an echocardiogram that the left ventricle is enlarged from the high blood pressure. Narrowing of the arteries that supply the heart muscle, those coronary arteries could be narrowed, and they can affect the heart muscle itself. And there's other conditions such as thyroid disease or excessive alcohol over time can damage the heart muscle. We call it an alcoholic cardiomyopathy. Obesity can also contribute for the extra work of the heart. And there's some conditions that can deposit things like iron can be deposited into the lung over an iron overload and cause heart failure. And there's other forms that can cause heart muscle failure, cardiomyopathy. And of course, irregular heart rhythms. If you have atrial fibrillation, the ventricular rate could be so fast that can cause the blood to backflow in the heart or not go forward. Sometimes a virus can affect the heart muscle itself. And I think COVID-19 is one type that can cause myositis or inflammation of the heart. Rarely flu viruses can cause this as well. That can cause a viral myocarditis that can cause heart failure. It can be the side effects of some medications, and again, other metabolic conditions like hemochromatosis or an overload of iron in the blood. We treat heart failure by treating those causes and risk factors, by treating the atrial fibrillation, managing the heart rate, controlling blood pressure, treating atherosclerosis, whichever way is required, and keeping diabetes under control. We always go on a low salt diet because that can cause more congestion and fluid retention and more work for the heart. And of course, we avoid excessive alcohol that can damage the heart muscle itself. If you're smoking, we ask you to quit smoking and give you support to do that as well. And certain medications can be used to improve the heart function. Most commonly beta blockers, which slow down the work of the heart, but also improve the contractions of the heart and the strength of the contractions. And drugs like Ramipril, which is an ACE inhibitor used for blood pressure as well. And if someone has excess of fluid on board, then we often use water pills or diuretics to take that fluid off to treat the symptoms. And of course, we treat reversible causes such as thyroid disease, anemia, and arrhythmias that create extra demand for the heart. And remember the whole message of our talks with empowering patients that self-care is the key to reducing risks and improving your lives. So know how to self-monitor, like your blood pressure and your daily weight, and understand your medications if you have these chronic conditions, and plan regular CDM visits, chronic disease management visits, if you have a chronic condition like congestive heart failure or diabetes or even high blood pressure. So with some conditions, we actually review periodically to check the patient's understanding of the condition, like heart failure and heart disease or kidney disease. Kind of go over their medications to make sure the doses are right and they understand what they're for. And look at the quality of life and their plans for the future, what they'd like to do more of, and what makes life meaningful for them. So it's been hard during the pandemic because we can't do most of them in person, because these visits usually take 20, 30 minutes periodically. Maybe you might do it once a year or a little bit longer, but whatever is required to support the patients in management of their chronic condition. And of course, our daily healthy habits, what we eat, what we do, and what we do for fun makes a big difference in the quality of life and our health as well. So that's a lot of information, a lot of technical information, but I tried to explain it in hopefully understandable terms. And I'm open to questions at the end to address it. But I wanted to give you kind of some key tips in case you go back to your doctor or a doctor in the walk-in clinic or in the emergency or a specialist, and you want to make sure you're getting all the key information that you need to make a decision about medication or treatment. So for every treatment or prescription or investigation that we do, including any of these cardiac investigations, number one, you need to know what is it for. So make sure you can understand in clear terms what the purpose of this treatment, whether it's a colonoscopy to check out the bowel, to find out the cause for bleeding or to remove polyps. Is it a prescription? What is it for? High blood pressure or for our mood or anxiety? Or is it for heart failure? Or other investigations such as an angiogram or an exercise test. What is it for? What condition? What are we looking for? What are we trying to treat? The number two question, what are the common risks from this treatment or this drug? Or what are the side effects, the things that are common from this particular thing that you're proposing? And then thirdly, what are the major risks, even if they're pretty rare? What is something that I would need to know that would make me decide I do or don't want to do this? I don't want to take the risk with it. So an example of a major risk that's not too common with a drug called prednisone that we might use for severe asthma or Bell's palsy, where the seventh cranial nerve goes into spasm and we get weakness in our eyelid or in our mouth, often treated with prednisone for a short course. So the common risk for prednisone would be it can cause a lot of heartburn, it can suppress your immune system temporarily. The rare major risk is for an overwhelming infection, or if you are an unlucky rare person that has loss of circulation to a bone, like the hip or the jaw. That's a rare side effect of prednisone that we do want to warn patients about, even though it's extremely rare. Because if that happens, we want to be able to say that we did tell the patient this is possible, but not likely. And of course, the most important that we often forget to offer is what are the alternatives? What happens if I don't do this treatment? What if I just watch and wait and just continue to see the blood in the toilet and not do the colonoscopy? So what are the risks of doing that? Or is there another way of checking it out? Or is there an alternative to this particular medication? Or are there some natural things that I can use instead? So those are the key things to ask about anything that we're proposing as healthcare providers. What is it for? What are the common risks? What are the major risks? And what are the alternatives? So in particular with drugs, you need to know what condition you're treating, like high blood pressure or my irregular heart rhythm or my heart function. What does this drug interact with or could interact with food or other drugs? For example, Coumadin, warfarin, the blood thinner, will interact with vitamin K and vitamin K rich foods like green leafy vegetables. They can block the Coumadin and won't work as well. But we can take, if you take other things like aspirin with it, it greatly increases the risk for bleeding. For any drug, you need to know the brand name, like Lipitor or Crestor, and the generic name, like atorvastatin. So usually the catchy name, the shorter one, is the brand name, and the generic name is the chemical name of the drug. A lot of my patients just remember the prefix to the generic name and not realizing the prefix is usually just the abbreviation for the generic drug manufacturer. So MINT is a common one I see. So MINT, donepezil, is a generic version of Aricept that's used for memory problems with dementia, like Alzheimer's disease. But the MINT doesn't tell us what the drug is. It's what comes afterwards that does. So MINT is actually just a generic drug company, same as APO. That's why you might have a lot of drugs that start with APO, but they're not all the same drugs. So know the brand name as well as the generic name. Know the dose in terms of something like milligrams, not just 1 pill or 2 pills or 1 teaspoon. And you need not only the dose, but the frequency. Is it once a day or twice a day? Is it at bedtime? So what is it for? What are possible interactions that you should know about with food or other drugs? What's the brand name and what's the generic name? And what's the dose and the frequency of that dosing? And you don't have to memorize this all, but once you have them, put it all on paper or ask the pharmacist to print it out for you. And certainly your doctor can do that for you as well and kind of go over what each drug is for. Because with a lot of chronic conditions, it could be pretty overwhelming if you need to take more than 3 pills and changing doses. So it's good. This is information that you should have in your pocket. And also in your pocket, if you see a doctor at a walk-in clinic or an emergency or traveling after the pandemic, it's really good to have in your pocket, especially as you get older, to have a list of the crucial history that any healthcare provider needs to know to treat you well. So number 1 is allergies to foods, but most importantly to drugs. 2 is family history. So significant things like cancer, premature heart disease, or diabetes, or high blood pressure. So you should know when the relative died and what they died from and what other major conditions that they had. You should have a list of major hospitalizations you've had in the year and the reason, major illnesses like pneumonia or COVID-19, major surgeries or operations and the date you had them done, and any other significant procedures or investigations such as your last colonoscopy and what was found. So it can be overwhelming, and do ask your doctor if you need help in kind of creating a summary. Because we all actually do have a summary. It's kind of required by the college that we have a comprehensive summary of your health history so that any colleague, if I'm sick and I have a colleague filling in for me, they can tell at a glance, just looking at 1 page on the electronic medical record, just like the old paper charts had a cover page. This summarizes all this information. And of course, any chronic medical condition should be on your list of information to share and carried in your pocket, purse, or wallet, such as diabetes or high blood pressure or heart disease. And of course, that list of your medications and those details that we went through. So this in a snapshot is, these are the things that you should know about your own medical history. And key questions I ask people to ask a doctor. I've actually had patients ask this right back to me after they've seen this talk. So if you're not sure if the doctor was rushing and really listening to you and got it right, it doesn't hurt to ask, what else could it be, doctor? Because sometimes when doctors in a rush, or we present with multiple different problems, we can really narrow down our differential diagnosis. So when we start talking and listening to your symptoms, we have a different idea of many things it could be. And as you talk, we provide more information, and then we ask particular questions, we narrow down that diagnosis. But if people are rushing or not listening, sometimes we can narrow it down too quickly and then make a mistake. So it doesn't hurt to ask, what else could it be, doctor? Because it just makes me think about, what could I have missed? And it doesn't hurt to ask, what's the worst thing it could be? Because we're always asking ourselves this question. If someone has a sore throat, it could be a strep throat, it could be COVID, but the worst thing it could be a growth or tumor in the throat as well. So you have to think about that. Could it be cancer? Could it be a stroke? Could it be a heart attack? The third question is, what would you recommend to your mother or child? Now, if you do ask it, the doctor knows what you're aiming at. And we're just making sure that you're treating me with the same care that you would treat your own family member. So I hope my patients don't feel that they have to ask me this question, because that's kind of our secret golden rule behind the counter, is that we treat everyone like family. But that makes the doctor slow down and think about, yeah, this is exactly what I would recommend or want for myself or someone that I cared about, because I care about my patient. So, as I mentioned, health is about achieving our positive potential. The heart is a muscle that improves with training, and we can't change our chronological age, but we can improve our physiologic age. And think about how fit can you be at this age right now. So, as you know, this talk was dedicated to my dad, and it's not just because I didn't buy him anything for his birthday yet, but he's a real role model on physical, emotional, and kind of social and spiritual well-being, that he is engaged, involved, and socially interacting with people in his community, physically active, totally independent, and really positive in spite of all the things we have to deal with in life, including the pandemic and the isolation that it's brought. But he definitely is much healthier than his chronological age. So I try to follow the example that he gives as well. I believe that each of us has a unique potential in life. And again, it's our duty, as I said earlier, to realize that potential and to help others achieve theirs. And with knowledge, engagement, and support, we can manage chronic health conditions and live well. So if any of you do have chronic conditions, I don't want you to feel down or depressed, because we all have the same most common chronic condition. So I wonder if you can guess what it is. So everyone in your room at home and on the Zoom call has the same chronic condition. It's incurable, it's sexually transmitted, and it has 100% mortality. So I think you guessed what it was. This chronic condition is called life. So let's make the most of it. So I invite you to share anything that you've learned with the people you care about, because heart disease and heart health is important for all of us and people in your lives as well. And again, we're here because we're part of this greater community, and you are our partners in spreading good health and including everyone in our community and making it a healthier future for Burnaby and all our communities. And just a little plug for my next talk with Leona is Thursday, March 31st. I planned it after I finished all my deliveries for that month. So I won't be interrupted. And it's about making sense of symptoms and screening tests, things that are sorely missed during the pandemic. So knowing that you can contact your family doctor, you could even go to a walk-in clinic if you need to do any of these tests. So I'll give you that key information on March 31st. So please join us for that one as well. Remember, healthcare is self-care, so please pass it on. So I wanted to bring Leona back on so she can let me know if there's any questions in the chat.
We do have a few. We have some great questions, but just to follow up, I did put the link to register for the March 31st talk in the chat. So take a look and you can just register today and you'll receive reminders a week out, starting a week out. So our first question is from Alice. She said, is it safe to take a baby aspirin a day, and when? If so, when?
It depends on your age and other risk factors. So we used to recommend a baby aspirin for everyone over 65, but not anymore. So you should actually talk to your family doctor if at your age it's appropriate. So it's not appropriate for everyone over age 65 or even over age 50. We actually found that there's higher risk for everyone to take an aspirin, a risk of abnormal bleeding, small risk for stroke, but high risk for getting an ulcer. So definitely the younger you are, the higher risk kind of outweighs the benefits for preventing stroke or heart attack. So only if you actually have established coronary artery disease or your doctor has told you that you should take an aspirin every day.
Great, thank you. Alice also would like to know, what is fibromuscular dysplasia, and is it fatal?
Fibromuscular dysplasia is an abnormality. It can include the blood vessels as well. So it can be a cause for strokes, heart attacks, or dissections. So it can be a genetic or idiopathic condition. So not necessarily fatal, but good to know because that's an increased risk factor as well.
Okay, great. If you have heart failure symptoms, is it okay to exercise? Vicki would like to know.
Actually, exercise is a part of the regular maintenance and therapy, but we have cardiac rehab programs that can actually guide you through what's the appropriate amount of exercise and what's too much. So with the Healthy Heart program that we used to have through our hospitals and community centers, they actually work with people that have cardiovascular risk factors, including heart failure or a prior heart attack or risk factors for that. And they would actually supervise and guide you through a healthy exercise. But if someone does have heart failure, then their cardiologist and family doctor can kind of go over what's the appropriate amount of exercise and how much is too much and when to contact us. So actually, we usually have kind of a one-pager of things to watch out for, like the weight gain, daily weights, managing salt, managing fluids. Inappropriate physical exercise is a big part of that too.
Great. Okay. Can diet and exercise remove plaque from the arteries?
Well, with an extreme vegan diet, it is possible to lower the cholesterol enough that I believe it was shown that it could regress heart disease. But it has to be pretty drastic.
Okay.
So you'd have to kind of, if you did have heart disease or significant now, and to talk it over, what you'd probably, if you did, then you probably have to do a combination of things, medication plus diet.
Okay, great. Are stents only inserted in emergency or urgent situations or after usual diagnostic reviews?
Oh, no, they're often done. They're not always an emergency. So people can have the symptoms of some chest pain or angina. And then when they do go for the test, we see there's a blockage of the arteries. It's only a small area. And they can plan to do the angioplasty and to put in a stent.
Great. So Lori and Colleen would like to know, can you explain the term congestive heart failure?
Yeah, so CHF, congestive heart failure, is actually exactly what we were talking about under heart failure. So it's decrease in the pumping ability of the chambers of the heart, mainly the ventricles, and it causes a backflow of fluid into the lungs. It gets congested, so we feel short of breath or wheezy with activity when we're lying down, or it can just all the way back to swelling in the legs and ankles. So the heart is congested, but then everything, it backs up all the way, just like a really bad plumbing problem at home.
Okay, thank you. Any suggestions for a good blood pressure machine?
Well, I don't work for LifeSource, but that's actually my most reliable machine because when patients are relying on a blood pressure machine, I do ask them to leave it at my office for a couple of days. So late at night, like 2 nights ago, 8 o'clock, when I'm finished on my patients and going through all the charts and stuff, electronic charts and tabs, then I have time to sit down with the mercury sphygmomanometer in my office with the patient's machine and then test it out to see how close they are. So I do it repeatedly because when we do it in the office, those machines are just too slow for us, especially in the time of COVID, because we're trying to limit face-to-face time. We got to deal with all the problems and do what we need to do to examine the patient. We don't want to wait 3 minutes for the blood pressure monitor to go up and they go down in each arm. So I prefer my patients to leave them behind, and usually within a couple of nights, I have enough time to check it out and to give it my stamp of approval. I usually note it in the chart when I last checked it. But I find the LifeSource, which is also called AND, like the word and, seems to be the most reliable. Omron is okay most of the time. Omron is one that's approved by Hypertension Canada, but I found that they're not always that reliable. But that's the one that's always on sale at Costco. So LifeSource you can find at other places other than Costco, like London Drugs often has it on Amazon. And you don't have to get the $100 one. There's a $50 version on Amazon. It's about $60 at London Drugs or Shoppers Drug Mart. I generally find those to be quite reliable for the systolic blood pressure. And I noticed that most machines tend to read the lower number, the diastolic pressure, a little bit too high. So they tend to overestimate that one. So kind of keep that in mind. That could be a difference in the doctor's office.
Great. Flora would like you to comment on brand name drugs as opposed to generic drugs. Is there a difference?
There probably is a difference with some older ones, like diuretics, like hydrochlorothiazide, probably doesn't make a big difference. And we actually don't have a lot of choice. So a lot of the times I prescribe a drug and I don't have any choice on which generic brand the patient's going to get. I won't say that drugstores get kickbacks from generic drug companies, but sometimes some drugstores favor a particular generic version or get a better deal from the warehouse for a particular generic version. I prefer drugs that aren't made in China, and it's not due to prejudice, but sometimes there's been some quality issues. So we've seen a lot of recalls on common drugs for blood pressure and other conditions, recalled because of impurities or quality control. And often they're made in certain other countries, like China. So sometimes I'm a bit concerned. And then that's led to a lot of shortages. Like amlodipine there, or Adalat, there was a shortage for a while. And a lot of common drugs that we rely on, we have to switch patients over to a different drug because there's a shortage because of a problem due to the main plant that's in another part of the world. So I don't think all generics are the same, but some of them are pretty close. Like Prozac, the name brand, and PMS fluoxetine, I believe are the same thing because they're actually made in the same plant. I think the company that made Prozac had their own generic version of it. But they're allowed to differ. There's certain ranges, so they could have maybe 90% of the drug effect and still be adequate. But that can make a big difference in certain drugs.
Great, thank you. Teresa is asking if you could address a dilated aortic valve.
Yeah, so if the aortic valve is dilated, then there's more backflow. So it's more regurgitation. So that not all the blood is going forward, kind of backflowing. So it can result, if it's severe, to congestive heart failure symptoms and shortness of breath.
Great. Looks like this might be the last question. Can you have normal cholesterol and still have plaque in your arteries?
Yeah, we probably all have some plaque in the arteries. So what they discovered during the World Wars is that healthy young men, like in their 20s, on autopsy would have all this gunk and plaque in their arteries already just in their 20s. Now, of course, it could have been like the diet in the 1940s with lots of sausages and eggs, but I still have patients that eat eggs and sausages every day. A lot of patients that eat eggs every day. So we already have some plaque in our arteries. And even if you have normal cholesterol your whole life, as we get older, we get more plaque depositing. That's why a normal cause of death when we're in our 80s would be a stroke or heart attack. It wouldn't be considered to be unexpected.
Great. So I think that's the last question. Lori and Colleen, you have your hand up. So did Dr. Wong answer your questions? You can unmute yourself if you'd like to talk.
Yes, he did. Question was answered. Thank you very much.
Great. Excellent.
Thanks,
and
Lori.
we've had some really lovely,
Lori
comments.
Lori was my high school yearbook supervisor.
Oh, really? Nice.
Yeah, very cool, wonderful patient. But I won't tell all the ways that he actually saved our lives and prevented us being expelled. But I guess I'm here also because of Lori. Thank you.
That's great. That's great. Well, I think you covered everything and put some very nice comments in the chat. So You're welcome. We're very happy to be able to do this program through the Burnaby Division. And yeah, my last comment will be that when I shut down the Zoom, there will be a quick survey that will pop up. If you wouldn't mind taking just a moment or two to answer those questions, it just gives Dr. Wong and I some valuable input on planning our program going forward. So
Good. Thank you all of you for spending time with Leona and myself. And have a good evening.
thanks. Have a good evening. Enjoy your long weekend.